Hi, good evening everyone. This is Dr. Manvita, Consultant Emergency Medicine at Yashoda Hospitals, High Tech City. Welcome to the online webinar sessions conducted on every Friday by the Department of Emergency Medicine, Yashoda Hospitals, Hyderabad. As you all know, chest trauma remains one of the most complex and time-critical emergencies we face, where every breath, every beat, and every decision matters. Today, we have with us Dr. Satish Babu, Consultant Emergency Medicine at SMF Hospital, Anur, Coimbatore, to discuss on the topic of chest trauma. Welcome to the program, Doctor.
Thank you.
Please start.
Yeah. Yes, thank you for that introduction. As you told very rightly, chest trauma is one thing we have to address at the earliest and intervene it. Let us see, another 10, 15, 20 minutes I'll take to discuss this chest trauma. Yeah, these lines are taken from ATLS. At the beginning of any chapter in ATLS, there will be a statement. In the chest trauma, these are the lines given. Thoracic injury is common in polytrauma patients and can be life-threatening, especially if not promptly identified and treated during the primary survey. Yes, this is the star line. Like in all chest trauma, if you don't identify and treat it initially at your primary survey, it is almost impossible to save the patient. So you need high suspicious mind and you identify immediately in the primary survey and react to that. You all know that chest trauma, most of the time, it is associated with polytrauma. Whenever there is abdominal injury, always suspect there may be a chest injury. Whenever there is a neck injury or a head injury, suspect chest trauma. So it is always associated with any other injury or polytrauma. So you should have as I told earlier, you should have a high suspicious mind to know whether it is chest trauma or identify whether it's chest trauma and treat it. As we all know that it is a great challenge, significant challenge in treating chest trauma in emergency department. Always chest trauma is divided into two: blunt trauma and penetrating trauma. Blunt trauma is usually it is you know that it is injury in either sports injury or a fall injury, or whenever there is a penetrating trauma, it is penetrating into your chest wall either through a gunshot injury or a stab injury. There are three physiological consequences, important physiological consequences in the chest trauma. Chest trauma. The first one is hypoxia, second one is hypercarbia, and third one is acidosis. Whenever there is a hypercarbia, there may causes a respiratory acidosis. It is due to change in the lung interthoracic pressure and also decreased level of consciousness. As I told, early recognition and treating in primary survey is very important, crucial in managing the chest injury. Hypoxia is the most serious consequences, and the goal of early intervention is to prevent hypoxia is the key in treatment. The absolute clinical knowledge and skill is required to treat a chest injury. The three important investigations, most important in treating a chest injury, is a chest X-ray, and all you know that EFAST and the CT chest play important role in identifying it and treating it. You all know that the primary survey is always airway with spine immobilization, breathing and ventilation, circulation with hemorrhagic control, disability and exposure. See, the most important in the chest injury is always breathing. Whenever you see a patient, you have to expose the patient completely, see the chest wall. Probably you have to remove temporarily even the C-spine collar, and you first assess whether the chest movement is normal, whether there is abnormal chest movements are there, and look for respiratory rate, whether there is a adequate respiratory rate is there, and look for the chest movements, and you can auscultate the chest, either any air entry is equal or not, and finally you can palpate the chest where you have to look for any tenderness, crepitus or any defect is there. So, what are the important signs of chest injury and hypoxia? Whenever there is an increased respiratory rate, you see there is a change in respiratory pattern, and progressively there may be shallow breathing will be there. That is very, very dangerous. Whenever you see a shallow breathing, then you may land up in a respiratory failure immediately soon after that. So, initial there may be respiratory increase in rate, there may be change in pattern, and following that there may be a shallow breathing. Yeah. What are the life-threatening chest injuries which you have to act very immediately or else you may be lose the patient? The four important giants life-threatening chest injuries are tension pneumothorax, open pneumothorax, massive hemothorax, and cardiac tamponade. Before going into the tension pneumothorax, I like to give a slide on the normal lung. Yeah, this is a normal lung. The normal lung parenchyma is covered with two pleura. One is visceral pleura and parietal pleura, and it is covered by intercostal muscle and ribs. This pleural space is very, very important. Whenever there is an injury to the lung parenchyma or chest wall, the air or blood enters into this pleura in between this parietal and visceral pleura, and then this causes inadequate breathing, hypoxia, respiratory failure, and patient may collapse. So this is the lung anatomy. Yes, now what you are going to see is most important is tension pneumothorax. Whenever there is injury to the lung or a chest wall, the air allows air into the pleural space, but it will not allow the air outside. Whenever there is injury to the chest wall or lung, the air moves into the pleural space in between this pleura, visceral pleura and parietal pleura. Whenever the breathing happens, the air moves into this space. This is called one way valve. There will be air leak will be there in one way, the other way it will not come out. Air is forced into the pleural space with no means of escape. Eventually lungs get collapsed, lungs gets affected, lungs get compromised, and breathing will be inadequate. Then it causes hypoxia. So there will be mediastinal displacement to the opposite side, and there will be a compressing opposite lung. There will be marked decrease in venous return, causing reduction in cardiac output, and finally it will end up in shock. This is called obstructive shock. What are the important signs and symptoms? Yes, there may be a chest pain, there may be air hunger, there may be tachypnea, tachycardia, respiratory failure, and hypotension. There will be again tracheal important signs, tracheal deviation away from the chest side of the injury. There will be unilateral absence of breath sounds, elevated hemithorax without respiratory movement. There may be a distended vein, neck veins. Then finally you may see a cyanosis. Whenever you see a cyanosis, and it could be a final symptom, and after that you may land up in cardiac arrest. So we have to act before getting cyanosis. So again, the tracheal deviation, the absence of breath sound, there may be elevated hemithorax and neck vein distension. How do you diagnose this? Most important diagnosis is clinical diagnosis. You see abnormal respiratory movement, you see respiratory one side unilateral absence of breath sound. Yes, you have to diagnose this as pneumothorax. And very quick and within a minute or within few seconds, your diagnosis is always with E-fast. Keep your probe on your chest wall and identify whether there is a pneumothorax or no pneumothorax. And finally, a chest X-ray will show you the tension pneumothorax or even a simple pneumothorax. Yes, the most important method nowadays we are doing to identify the tension pneumothorax is E-fast. Take a probe. It may be a most commonly linear probe in a supine position, and keep the probe in multiple intercostal space. Yes, this is how the normal lung parenchyma appears. Yes, you can see a subcutaneous tissue, chest wall muscle, and bilateral rib. You can see in here it is a pleural line, and these are lung parenchyma in between the rib shadows, in between ribs. So this is a normal one when you keep your ultrasound probe on your chest wall. Yes. After viewing that, put an M mode. You see, whenever you put an M mode in normal lung, looks like this. Yes, you can see a subcutaneous tissue, pleural line, and following a lung parenchyma. This is almost looks like a seashore or beach appearance, a waves, sand and wave appearance. This is called seashore appearance, a normal lung in M mode. So whenever you put an M mode, whenever you see a pneumothorax, yes, the first thing you have to note this absence of lung sliding. This lung pleural line will slide usually when there is a normal breathing. Whenever there is a pneumothorax there, it will be the lung sliding movement will be absent or it will be less. Yes, here what you see on this right hand side is a barcode sign or you can call it a stratospheric sign. So you see a M mode, you see a barcode like this. Yes, it is a diagnosis is pneumothorax or a tension pneumothorax. You see immediately this, you diagnose it and you have to act it immediately. This can be done within few seconds. What is this? This is again a chest X-ray where it is completely collapsed lungs, and most of the lung part is with air. So what it is completely air filled up and a small amount of lungs is seen. And whenever you see this kind of chest X-ray, it is called as tension pneumothorax, and we call this act as something called criminal act. Why you call it as a criminal act? Yeah, this amount of tension pneumothorax is seen, must be diagnosed clinically. It should not be confirmed with chest X-ray. Diagnose it clinically. Probably take a few seconds with your ultrasound. Immediately act immediately. And what do you act immediately? What is immediate line of treatment? Yes, it is a needle thoracocentesis. Immediately put a needle in the thoracic cavity and decompress, release the air. Yes, needle thoracocentesis. Yes, whenever there is a chest wall thickness is more and there is a less success rate of needle thoracocentesis. So chest wall thicknesses influences the success of needle thoracocentesis. If you have a 5 centimeter needle catheter, it will reach the spural space 50%. Whenever you have more than 5 centimeter up to 8 centimeter, there is always a 90% chance of successful needle thoracocentesis. Here you see here is a orange color is the highest, largest catheter we have. You put a orange catheter almost more than 5 centimeter. Needle needle height is there, so there is a more success for needle thoracocentesis. So ideally use orange or a gray or a 14 gauge or 16 gauge to get the successful needle thoracocentesis. The recent evidence supports placing a fifth intercostal space slightly anterior to mid-axillary line. Previously, we used to say that second intercostal space mid-clavicular line. Now it is more evidence towards fifth intercostal space slightly anterior to mid-axillary line is the recent guideline for needle thoracocentesis. For a child, it remains in the second intercostal space. Yes, the finger thoracotomy is also is an alternate approach for a needle thoracocentesis. Successful needle decompression converts tension pneumothorax into simple pneumothorax. So it is converted into simple pneumothorax. For this simple pneumothorax, again you need ICD tube. So ICD tube is mandatory after needle decompression. Any tension pneumothorax, the ICD is mandatory. You cannot stop with needle thoracocentesis. You have to go for ICD. So what size ICD we can put? So nowadays the concept is smaller size ICD is more than enough. Less than 20 is more than enough. It is idea is to remove the air only. Whenever there is a pneumothorax, go for a smaller size. Whenever there is a hemothorax, go for the larger size ICD. Yes, open pneumothorax. Yes, again the injury on the chest wall that remains open can result in open pneumothorax. Also is called as a sucking chest wall. Whenever the injury happens to the chest wall, you see a open injury to the chest, and this causes pneumothorax. It is called open pneumothorax. Whenever this opening is approximately more than 2/3 of diameter of trachea. So whenever you have a tracheal 2/3 of tracheal size opening in the chest wall, this can causes open pneumothorax. So air passes preferably through the chest wall defect with each inspiration. So air move inside with each inspiration, and air is filled up in the again in the pleural space. It causes open pneumothorax. Yeah. This is a three-corner tapered dressing. The three side it is closed, and you can open it on one side. This can be done even in your pre-hospital setup before reaching hospital. You can do that. This is again it is called as a flutter valve effect. Tape it secure on three sides to provide flutter valve. As patients breathes in, dressing occludes the wound, preventing air from entering inside the pleura. Whenever the patient breathes out, the opening end of the dressing allows the air escape from the pleural space. So breathe in, the dressing occludes the air to come inside the pleural space. Breathe out, so it allows the air move out of the pleural space, and this is will be effective in treating the open pneumothorax. So you cannot stop with this three-way occlude. You have to place a chest wall. Where you place the chest wall? Chest tube. Sorry, we can play. You have to place the chest tube. So chest tube should be placed removed from the wound as soon as possible. Subsequently, you can do a surgical closure of the wound. So whenever you see open pneumothorax, again you have to go for an ICD. You can do the ICD little away from the open pneumothorax area. Yeah, again now you are moving to the one more important topic, massive hemothorax. Whenever there is a rapid accumulation of a blood more than 1500 ml of blood inside your chest wall, it is called as massive hemothorax. It is most commonly it is due to penetrating penetrating injury where it injures your systemic or hilar vessels. So compressing the lung and preventing inadequate ventilation and it causes hypoxia. Inadequate oxygenation ventilation is the primary problem in the massive hemothorax. So what are the clinical findings? Neck veins will be flat instead of distended, where you can the mediastinal or tracheal shift is always rare. There could be seen absence of breath sounds and dullness on percussion. See, when compared to the tension pneumothorax, breath sounds will be decreased. It may not be absent, it will be decreased. Whenever you do a percussion, it will be dull in the hemothorax, hyper resonant in the tension pneumothorax. The tracheal deviation is rare in the massive hemothorax, but it will be more it is in the tension pneumothorax. Yes, distended neck veins will be in the tension pneumothorax, whereas absence or collapsed neck vein is seen in the hemothorax, maybe due to hypovolemia. Yeah, this is the X-ray where you can see a massive hemothorax. One side of the lungs is occupied with blood. Yeah, this one is again, yeah, ultrasound E-fast. You can see here is left hand side. You put a convex ultrasound probe. You can see this kind of pleural fluid in between the pleural sac. Whenever you put a linear probe on your chest wall in between the pleura, you can see this blood collection between this pleura. Okay, how do you manage it? Put a large IV cannula, go for crystalloids initially, and at as early as possible do a blood transfusion, uncross matching or cross matching. Blood transfusion must be done whenever possible. If it is appropriate, collect the blood coming from your chest tube in a sterile manner. Collect it, and appropriate device is there. You can do a auto transfusion. It is rare, but whenever you have appropriate device is there, you can do it, and immediately probably 28 or 32 French chest decompression can be done. Following that, auto transfusion can be done. And most important thing is blood transfusion at as early as possible. And surgical intervention is very must and important, and thoracotomy is important in managing massive hemothorax. You cannot stop with ICD or blood transfusion. Most of times you need a surgical correction to prevent further loss in massive hemothorax. So what are the indications for this thoracotomy? Immediate rush of 1500 ml or more amount of blood is indicated for thoracotomy. If it is less than 1500 ml of blood but it continues to bleed for more than 2 to 4 hours, 200 ml per hour blood is being collected for the next 2 to 4 hours. Again, it is indication for thoracotomy. The persistent need of continuous multiple blood transfusion is also an indication for thoracotomy. Yeah, so the another important topic is cardiac tamponade. Whenever there is a compression of heart by accumulation of fluid inside the pericardial sac, results in decreased cardiac output. So the human pericardium is with a fixed fibrous sac. Even a small amount of the blood inside your pericardium, small amount of blood inside your pericardial sac can always decrease in cardiac filling, cardiac output. This causes hypotension, and it causes big cardiac tamponade and collapse and respiratory failure and hypovolemic and shock. So commonly it results, most commonly it results in penetrating injuries. So what is this classical triad you say in this clinical finding, you say in this cardiac tamponade? The first one is rise JVB, hypotension, muffled heart sounds. This is called as Beck triad. But Beck's triad, what I say is, how many times you hear this muffled heart sound in your busy emergency room or a resuscitation area? It is always difficult to identify muffled heart sounds. Sometimes you may not see a rise JVB. Whenever there is associated hypovolemia, associated any other injuries or hypotension, there may not be a raised JVP. So Beck triad is always difficult to identified in a busy emergency room. So it is always identify this. Always you have to look for alternate way of identifying this cardiac tamponade. That alternate way is best is to do an ultrasound e-fast. Yes, again, pulsus paradoxus is again another sign. Pulseless electrical activity in absence of hypovolemia, you always suspect cardiac tamponade. Yes, this is yes, this is a massive collection in the pericardial sac. You see here collection of blood inside this pericardial sac, and you can see a very limited cardiac activity. This requires immediate attention, immediate treatment. What is the immediate treatment? Yes, pericardiocentesis is the immediate treatment. Put a needle in a subxiphoid area, 45-degree towards your left shoulder, pass the needles, Hildinger's method, pass the catheter inside and collect all the pericardial blood outside. This is called pericardiocentesis. So what is a definitive treatment? Again, definitive treatment, you have to go for thoracotomy or sternotomy of following pericardiocentesis. Yes, now we are from primary survey, we are moving into the secondary survey. In-depth examination, do multi-para monitoring whenever needed, and do an ABG. An upright chest X-ray will give a fair idea. Whenever patient is stable, the gold standard is always do a CT scan. Whenever you patient stable, patient is there, go for the CT scan, and lab investigation will give a clue. Yes, potentially lethal injuries, life-threatening injuries, we move into potentially lethal injuries. Even you say this as potentially lethal injuries, even this list of injuries are very, very life-threatening. You may need immediate attention, you need immediate diagnosis, and then following that, you need a definite treatment. What are the potentially lethal injuries? Simple pneumothorax, hemothorax, flail chest, pulmonary contusion, blunt cardiac injury, traumatic aortic injury, or traumatic diaphragmatic injury. Let us see some of the few of these injuries before concluding my talk. Yes, the first one is simple pneumothorax. Again, the air entering the space between the visceral and pleural pleura, where it causes a simple pneumothorax. Lung laceration with air leakage is the commonest cause for the blunt trauma. This can cause a simple pneumothorax. You all know that compare both side of the air entry and decrease it will be decrease on the affected side. So how do you get it? Get it upright expiratory chest X-ray will give a simple pneumothorax clue. How do you treat that? Yes, best treated with tube on fifth intercostal space in the anterior to the mid axillary line, probably connect to the underwater seal apparatus with or with suction apparatus. You all know that even a simple pneumothorax needs ICD whenever you're giving a positive pressure ventilation. Whenever you're having a simple pneumothorax or a mild pneumothorax, you want to put a patient in a BiPAP. Yes, this positive pressure airway can cause this simple pneumothorax into tension pneumothorax. So whenever a patient is intubated, you have a simple pneumothorax, or whenever a patient having a CPAP, BiPAP, and you having a simple pneumothorax, you have to put an ICD to allow this to prevent the simple pneumothorax into tension pneumothorax. Whenever you have a simple pneumothorax, you want to airlift the patient. Yes, again ICD is must. Yeah, this is ICD with underwater apparatus with suction. Yeah, next one is flail chest. Whenever you are dealing with the multiple rib fractures, whenever a segment of chest wall doesn't have bony connectivity with the rest of the thoracic cage, you call it as flail chest. You have a paradoxical air movement, paradoxical breathing will be there in the flail chest. Yeah, flail chest will causes pulmonary contusion. The pulmonary contusion causes a pain, and following that, there will be restricted chest movement, and finally causes hypoxia. Pulmonary contusion and hypoxia, these two are important in the flail chest. So treating these two always a primary goal in treating the flail chest. Yes, adequate oxygenation and ventilation is needed. And most important, along with oxygenation, you have to give adequate analgesics, either IV infusion, narcotic drug infusion, or even a intercostal nerve block or epidural anesthesia will help in relieving the pain. This will allow you to adequate ventilation. Whenever it is required, maybe 24 hours or 48 hours intubation and ventilation will help you in treating the fly chest. Yes, now we move on to the blunt cardiac injury. Probably the most common is always a motor vehicle collapse. Whenever a pedestrian is walking, hit with a vehicle, he may land up in blunt cardiac injury, or there may be a fall from height can cause a blunt cardiac injury. Blunt cardiac injury causes injury to the cardiac chambers, or it may be injury to the cardiac blood vessels. Yes, ECG, you see a multiple PVCs, unexplained sinus tachycardia, atrial fibrillation, there may be a bundle branch block. There may be signs of cardiac tamponade. Yes, you see a cardiac tamponade, you know what to do. And there may be sudden arrhythmias, VF or VT or AF, and you have to treat this arrhythmias immediately possible. That is the reason whenever you see a blunt cardiac injury, you have to monitor in ICU for 24 to 48 hours. Yeah, this is again a life-threatening. One more injury is traumatic aortic disruption or a traumatic aortic injury. The common cause for sudden death immediately after a vehicle injury or fall from the great height is a traumatic aortic injury. The best survivor is always have an incomplete laceration near ligamentum arteriorum of aorta. Identify it as early as possible. You can salvage the patient. If you miss it in primary survey and secondary survey, definitely you are not going to save this patient. You have a high index of suspicion prompted by history and characteristic finding on chest X-ray. What are the finding in the chest X-ray? Yes, widened mediastinum, obliteration of aortic knob, deviation of trachea, depression of left main bronchus, or maybe a deviation of esophagus. This could be a signs in your chest X-ray, but always difficult to find this kind of findings. If you want to identify this kind of findings, you should have high suspicious mind. How do you manage if patient is stable? You can do a CT chest, a contrast CT chest. This could give a blunt aortic injury. You can always give a short-acting beta blocker, esmolol especially, and keep your heart rate less than 80 beats per minute, and BP control a map of 60 to 70 mm. Once you identify is at the early surgical repair, most commonly endovascular repair is the most common, and if you're able to do this, you can save this patient. But most of times, if you delay in identify, and most of the times it is even difficult to the shift to the surgical patient before that patient may collapse. So this is very important. Identify early and treat early. And the last and final one is traumatic diaphragmatic injury. Whenever diaphragm is torn or damaged due to blunt or a penetrating trauma. Most commonly it happens on left hand side. You can see this bowel contents is displaced into the chest wall. You can also even see the NG tube in the left chest wall. How to identify it? Take a chest X-ray or a CT scan. You identify a traumatic diaphragmatic injury. How to treat it? It is a direct surgical repair of diaphragm. He will give a treatment to this. Yes. This is the. You can see this diaphragm is injured, and you can see the abdomen content is moving into the diaphragm. And you see a displaced mediastinum. Yes, you can see a elevated diaphragm in the chest X-ray. And again, here CT chest, you can see that diaphragmatic injury. So seeing this, you have to act immediately, and surgical treatment is the othermost treatment. So again, this kind of injuries you need suspicion in mind and go for the investigation as it's required. Coming to the conclusion, yes, as I told earlier, most commonly chest injury is associated with polytrauma. It will not come as a single injury, but most of the times it is commonly associated with some other injuries. You have to identify it promptly and treat it during the primary survey itself. You cannot take it longer. It should be treated in primary survey itself. And all emergencies we should develop the ability to recognize this important injury, and say you should have develop a skill to treat this, and you have to adopt this life-saving procedures. In pneumothorax, don't intubate and ventilate without placing an ICD. It has to be done simultaneously. Someone simultaneously put a needle. Needle thoracocentesis, needle place your needle inside your chest wall, and simultaneously someone has to go for intubation, and simultaneously someone has to prepare for ICD. It should go hand in hand. So yes, one person cannot handle chest trauma. You should have a highly qualified highly qualified emergency team and a surgical team to save the patients. Thank you all. Today happened to be birthday of Dr. V.P. Chandrasekharan, my boss. Wish you happy birthday, sir. Wishing you happy birthday, and I conclude my talk. Thank you very much.
Happy birthday to the sir, and thank you so much for the wonderful section, Dr. Satish.
Thank you. If any questions is there, I can take up.
1 second. We have one question.
Yeah.
How can we improve pre-hospital triage and initial management of chest trauma?
Yeah, again, as I said, it is very important to teach your paramedics and your emergency postgraduates how to identify this chest trauma. As I said, you should have a suspicious mind. You should have a knowledge. You should have a skill. So it is we have to keep prompting what are the signs and symptoms of chest injuries, and you have to allow your paramedics and postgraduates to attend workshops related to chest injuries, and this will help you to identify the injury, and whenever you treat this chest injury in pre-hospital level, you should have 100% result. If you don't identify at pre-hospital level, definitely it becomes a mortality, and morbidity is more to the patient. Yeah, the pre-hospital care is very important, and training sessions is most important.
And one more, sir, how do we prioritize imaging modalities in unstable chest trauma patients, either fast or chest X-ray or CT?
Yeah, the number one investigation priority is do a fast, do a lung ultrasound. Most of the times, life-threatening injuries, especially tension pneumothorax, tension pneumothorax, massive hemothorax, or a cardiac tamponade. Big three you can always identify it with your ultrasound. So priority is ultrasound. You identify it, you treat it. If patient is stable, come on, take a chest X-ray. If his patient is more stable, always do a CT chest. It will give you absolute diagnosis. So priority is clinical findings. Number one is clinical findings. Look your chest movements. Look for your air sounds. Look for your tenderness, palpitated, see any crepitus, any defects are there. This is number one. And number two, as important as clinical findings, number two is lung ultrasound. If you're able to do these two, 90% you can identify these life-threatening injuries, and the rest of the things you can take a chest X-ray or a lung for CT lung. Yes.